Everyone, my name is Ines Rio. I'm the head of the GP Liaison Unit at the Royal Women's Hospital. Welcome to this evening's session on perinatal mental health and psychotropic medicines in pregnancy. It should be an excellent session. We've got about 3 major talks going through it. And currently we're due to finish at about 8 o'clock at night, but we might go for 10 or 15 minutes more. So please feel free to leave if you need to, but also perhaps just get your dinner if you feel like it, a glass of wine and a cup of coffee. I'd like to actually start off acknowledging on behalf of the Royal Women's Hospital, North Western Melbourne Primary Health Network, PANDA and the Parent Infant Research Institute, and acknowledge that the traditional custodians of the land on which we're working, the Wurundjeri Wurrung people, the Bunurong people, the Wathaurong people, and wherever you may be today. And we pay our respects to elders, past, present, and emerging, as well as pay our respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just some housekeeping. All attendees are muted. Please ask questions via the Q&A box only. And at the end of each presentation, I'll put forward a few questions based on those Q&As. And the questions will be asked anonymously to protect your privacy. Please ensure you join the session using the same name as your event registration, so the North West Melbourne Primary Health Network team can allocate the appropriate CPD and certificates for you. And if you're not sure that your name matches, please send a chat message to the education unit via the, I think it's the chat part. Prior to starting today's session, I'd just like to thank, in anticipation, Eliza, Yvonne and Adila from North Western Melbourne Primary Health Network and Emily Lawson from North Western Melbourne, from the Royal Women's Hospital GP Liaison Unit for assisting in tonight's presentation. So over to the Health Pathways team. Adila, I think you're starting.
Thank you. I will start sharing my screen. So hi everyone, I'm from Health Pathways Melbourne, which is a collaborative program with, I'm sorry, can you see my screen?
Yes, we can.
Apologies.
It's not a slideshow. Yeah.
There you go. So Health Pathways Melbourne is a collaborative program which is run by Eastern Melbourne PHN and Northwestern Melbourne PHN, and it is supported by local GPs, hospitals, health networks, community health providers, and other health professionals. It is a single website that provides clinicians access to a comprehensive collection of locally relevant clinical information and guidelines that are designed to support GPs and other healthcare providers in delivering consistent and evidence-based care to their patients. It includes medication information, referral information, and further resources which can be used at the point of care. Say a GP is new to the area and not very familiar with perinatal mental health, they can jump online to Health Pathways to check the local assessment, management, and referral criteria for services within their catchment. This slide shows you the main page with the latest health alerts for Melbourne and the Pathways updates, and a snapshot of the table of content on the left of you of the different health conditions that the pathway exists for. And the table of content can be used to navigate to the relevant conditions or by using the search function on the top of the page. Here is a little overview of the relevant clinical and referral pathways for perinatal mental health. All pathways undergo a full review and are updated every 3 years with the help of a clinical working group. Consists of a clinical editor, GP reviewers, subject matter experts, pharmacists, and other relevant stakeholders. Service updates are also done on a case-to-case basis when there are criteria changes to the clinical pathways, and they will be updated earlier than 3 years to the normal 3-year review cycle, should there be any clinical and guideline update. And Clinicians who work in the Eastern and Northwestern Melbourne catchment can register to access Health Pathways Melbourne by visiting our website and creating your own individual account, which will give you immediate access to the website. I will also post further information in the chat on how you can access. And if you have any questions, please send them through. And thank you for listening.
Thank you very much, Adela. I will now go back. That's great. And certainly many of the GPs use it. So we've got 3 sections tonight. The first one is on supporting new parents, their babies and families by PANDA. We then have a section from the Royal Women's Hospital, Charles Sue, on perinatal mental health and psychotropic prescribing perinatal period. And then we have a section on period on online resources and support. So to start off with, introducing our 2 speakers from PANDA. Kirsty Aldridge is the National Helpline Manager for PANDA. She's over 20 years of experience working with the public, private and NFP sectors at SEN operational and strategic levels. She's successfully managed national programs and overseen significant digital transformation project with a focus of improving community outcomes through service delivery improvements initiatives. Bonnie Jeffcott is the practice liaison lead at PANDA with over 15 years of experience in counselling, training and health writing. Bonnie's worked at PANDA since 2017 in several roles, including helpline, community education and training, and communications and management teams. So over to you, Kirsty and Bonnie.
Good evening, everyone. Just wanted to say on behalf of myself and Kirsty, thank you for having us. I'm just going to share our slides. Okay. So first of all, we'd like to acknowledge the traditional owners and custodians of the lands we live and work on and pay our respects to elders past, present and emerging. The gorgeous artwork that we can all see on screen at the moment is by Mel Barton of Alkira Indigenous Art. It was commissioned by PANDA and represents the importance of community and connection when navigating perinatal mental health challenges, aligning with core First Nations beliefs and values of supporting community and different levels of care to those who need it most in their darkest times. We'd also like to acknowledge the individual and collective contributions of all people with a lived and living experience of perinatal mental health and suicide challenges, and those who love, have loved and care for them. The voices of people with lived experience are essential to informing, supporting and transforming the services that we deliver at PANDA. You'll see on screen at the moment, this is a quote from one of our PANDA community champions. We have over 200 lived experience volunteers that work tirelessly in the community, advocating for change and raising awareness about perinatal mental health issues. And I think this quote from Nick just so beautifully encapsulates the fear and the barriers to care and the stigma that many parents are managing when they're trying to access support for themselves and their little ones. Here's a brief introduction to the learning objectives. We will do our level best to get through this as quickly as possible because we're aware that there are some fantastic presentations from Charles Sue and the team at Peri as well. So we wanted to provide a brief overview of perinatal mental health in Australia. Perinatal depression and anxiety are 2 of the most common mental health conditions, affecting over 100,000 Australian families every year. Charles will be talking more in depth in his presentation about antenatal and postnatal anxiety and depression. So what we'd like to do is really have a look at the similarities, often the presenting concerns, the signs and the symptoms of perinatal mental health challenges, and there can be some overlap and similarities between them. So for instance, we know in Australia, up to 1 in 3 mums and birthing parents experience childbirth related trauma. Dads and non-birthing partners and healthcare providers who are assisting at birth can also experience secondary and vicarious
Sorry,
trauma.
I'm just going to interrupt. We can't see the screen that you're
Oh.
shared PowerPoint. I can share it if you want me to share mine, but I thought you wanted to share yours.
Oh, we did. I'm so sorry. I'm just
That's all
battling
right.
along and I thought you could see the screen. Let me just.
Mine if it's hard. Do you want me to do that?
I'll see if I'll just try again.
Yeah, it looks like you're about to. Yeah, now you're sharing it. Well done.
Beautiful. So sorry. All right. So we will just go through. There's Mel's gorgeous artwork and some quotes from our lived experience champions as well. So we were just starting to talk about birth trauma and also intrusive thoughts. So many parents that call the helpline share with us experience of either unwanted, distressing, frequent thoughts of accidental or purposeful harm coming to their baby. For a lot of, it's so important to speak to parents about their history for childhood sexual abuse survivors, for instance. It's incredibly common to have thoughts of sexual harm to bub. And what that might present like is if there's thoughts of someone else harming bub, it might be hypervigilance, not wanting anyone else to care for the infant. Or for a parent that is worried that they may do something to hurt their bub, it may look like avoiding things like nappy changes, bathing. So often what parents talk about, and it may appear to be the beginnings of anxiety or a little bit of an overwhelm, particularly for first-time parents. It's absolutely crucial that we check in around how was your pregnancy? How's your birth? How are you? Just as a baseline, beyond any screening, and we'll have a look at some screening measures in a moment, but how are you traveling? And do you have any safety concerns for yourself or someone else? Or are you having any thoughts or feelings that are distressing or upsetting to you at the moment? So the hypervigilance, the avoidance, missed healthcare appointments are pretty common. So particularly if it's a clinical setting where someone's experienced birth-related trauma, unwell bubbers in NICU, that particular experience as well. We speak to so many parents on the helpline that are presenting with really acute distress about their pregnancy, birthing, or postnatal experience. And due to the unrelenting societal pressures to have the perfect baby, the perfect experience, I'm coping well, I'm absolutely loving this, there is an absolute underbelly of distress that parents in our community are managing as best they can by themselves. But repeated surveys that we've done at Panda, we know that parents often, I think the last survey, the last time we had a look at the data for parents calling Panda for the first time, 54.8% of our callers had not disclosed their mental health concerns to family, friends, or healthcare providers. Surveys that we do with our consumers in the community, often parents will report, I remember doing a self-report measure, but there wasn't follow-up, or I had an awful experience and you're the first person that's talked to me about it. So that baseline of how was your experience, whether it's pregnancy, birth, or postnatal and parenting? Do you have any safety concerns for yourself or for Bob or someone else? And is there anything that's distressing you at the moment? So the statistics, so we've just got some information about each of the conditions, the very common conditions like birth-related trauma, perinatal psychosis. It's a rare but incredibly serious condition, usually always results in a hospital admission, often for mum and bub. Best practice is that parents and their infants are admitted together to preserve that attachment bond. But particularly, and at the moment, we don't have any validated screening measures for perinatal psychosis. Prevalence rates during pregnancy are much lower. I think it's around 2.9% of mums and birthing parents. So parents with a pre-existing psychotic-like disorder may experience psychosis-like episodes during pregnancy. but we're particularly looking for that sudden onset. One of the first warning signs, and all of our community champs talk about this, is that absolute inability to sleep. So it might be an elevated, euphoric, quite manic presentation, but if you have a parent in your care, they've had a bub within days or weeks, usually the onset is the first few weeks after birth. Often that first warning sign is that absolute inability to sleep. It may not present like kind of classic psychosis in terms of a lot of parents do experience auditory disturbances, so visual, auditory, olfactory hallucinations, delusions of thought. But we speak to callers all the time that will contact us either prodromal for psychosis or in the middle of a psychotic episode. Partners and family often call us with concerns as well. And often in that perinatal period, we're looking for inability to sleep and a lot of confusion. Parents will often report, it could be as simple as, I don't know what's happening at the moment, but something just does not feel right. And it can be life-changing and life-saving. Most parents that receive support for acute perinatal mental health go on to make a full recovery with relief from signs and symptoms of perinatal mental health. And our peer practitioners that work on our helpline and our community champs that volunteer with us are a testament to living a rich, beautiful, rewarding life, regardless of diagnosis and perinatal mental health conditions. So really meeting parents in some of their most vulnerable moments and supporting them to access the care that they need. I've just realised I've just better hustle along and move on to the next slide. So just briefly, we did just want to mention a couple of screeners because we often support healthcare providers on the Panda helpline and via our secondary consultation service that are wanting to provide additional support to parents in their care. So the Centre for Perinatal Excellence's Australian Clinical Practice Guidelines do recommend the EPDS and the ANRQ as the one to screen for perinatal anxiety and depression. That's the EPDS, and the ANRQ for psychosocial risk factors. It's well worth having a look on COPE's website. They've got the screeners, they've got the scoring guides, as well as I think there's updates to the ANRQ partner version with additional items assessing substance use and family violence for partners. Obviously, with the screeners and what I touched on before, with that feedback from our community, parents are so eager to have conversations with us as healthcare providers about their mental health, about their well-being, their parenting, changes to relationships during the transition to parenthood. So we'd really strongly encourage you to, when considering administering a screener or an outcome measure, that follow-up, that care conversation that goes alongside that screener, exploring, trusting parents as the experts in their own lives, that they will have a sense of what's helpful in terms of self-support and what they might like to consider in terms of referral options. So the appropriate follow-up and referrals are absolutely key there. And that's something that Panda can support you in your practice with as well, in terms of having a look at suitable options for parents in your care. Just want to quickly mention the Kimberley Mum Mood Scale and the City Birth Trauma Scale. They were both included in the COPE Australian Clinical Practice Guidelines, but there weren't consensus recommendations. I'd encourage everyone to have a look at both of these options for screeners, particularly the KMMS if you're supporting any First Nations families. There's an introduction to the KMMS available on the Emerging Minds website. The research team is always happy to hear from clinicians that are interested in the adaptation of the EPDS that has the scale, and then a second section called the YARN, which is that psychosocial assessment and conversational piece of really checking in around mum and bub's wellbeing. And the City Birth Trauma Scale was validated for use with the Australian population a couple of years ago. I'd also just like to check in quickly just around people from multicultural communities, dads and non-birthing partners. There's quite a variance in terms of the cutoff scores. For the EPDS, for instance, it's much lower for dads, and for women and birthing people from multicultural communities. And there's some question around the validity of the use of these scales. So when Panda's been administering the EPDS with a caller that speaks to Aspire and interpreter, for example, the Victorian Transcultural Mental Health Centre does have translated, validated versions of the EPDS in particular. So just those considerations around adapting our care for priority populations. And again, our secondary consult team is happy to have a chat about that if anyone's interested.
Bonnie, I just thought I'd let you know you've got 5 minutes left. Thank you.
Okay, thank you, Kirsty.
Cheers, Bon. So the next slide is just articulating how we then deliver that beautiful, rich service to our community. So we've got predominantly the National Helpline, which is providing counselling and peer support, which is sort of low to moderate brief intervention support via a telephone line. We've then got the intensive care and counselling support, which is around care coordination and really gathering all those referral pathways and additional support that an individual and the family and support network might need. And then we've got the secondary consultation service, which is a national programme, and that's available to healthcare providers to obtain expert and considered consultation with our practitioners relating to their care and support. We've got 3 of those specialist programmes as well, supporting young women in prison who might need some help and support. We've also got the Mum Mood Booster programme that we refer and deliver the 6 coaching sessions to our community. And then we've got a specialist programme for baby and partners and fathers to help provide that professional support if needed through the SMS for Dads programme in partnership with the University of Newcastle. You just move on to the next slide, Bon. Yep. This is just a really beautiful visual in terms of our approach. So as with any mental health support provision that we provide, there's a model of care that underpins how we actually deploy, deliver and consistently make sure that we're putting our community and our workforce at the heart of everything that we do. So this is just a beautiful visualization that articulates how people can access Panda, our assessment approach, the services that we provide, and then all of those referral pathways. In terms of what callers can expect, look, we're a non-judgmental, inclusive, trauma-informed counselling and peer support. We are person-centred. We actually, put our community at the heart of everything that we do. There was a helpline review in 2023 that was really driven by community outcomes and community needs. Initially, the call can last between 20 and 60 minutes, but it's not capped. We'll meet people in the moment where they're at. And if that needs to be a 90-minute call, that's what we'll deliver. And that's, again, delivered via counselling or peer support call. And like Bon's already said, it's a real opportunity for them to share their story. And part of that referral and follow-up call management is making sure that that individual doesn't have to repeat their story. So we act as that conduit between those referral pathways to make sure that that individual doesn't have to tell their story over and over again. So we continuously make sure that we're giving the individual what they need in that moment. Next slide, Bon. Just a quick overview, as you'd expect, predominantly most of our community that access Panda services are based in Vic and the main larger states, so Queensland and New South Wales. We are seeing an increase in those regional and remote areas, and we're also seeing a slight increase in the youth. That's an emerging theme that's probably happened over the last 2-3 months, where we're starting to see an increase in those young mums aged between 17 and 19 years old. And we expect that to increase over the next 2-3 months. We've also seen an increase in our First Nations community group. That's almost doubled from 3% in the previous year to around 6%. In terms of the activities, it's quite significant. We're a small but mighty organisation, so we've delivered just under 64,000 activities, of which 77% of those activities have been a successful conversation with a service user. We're hearing more and more from neurodiverse individuals presenting with acute mental health distress during the transition to parenthood, which is something that we're really starting to understand, those emerging needs and how we can adapt the way that we deliver those services. The next slide is just really what you'd expect in terms of those presenting concerns, of which we are seeing more and more individuals presenting with multiple quite complex primary concerns. So, you know, we have to lean into that and make sure that we're really leaning into those different programs and service offerings to make sure that those individuals get that brief intervention support, but also we facilitate the longer-term intensive care support and any of those secondary consult interventions that we can help support with managing those individuals. That's something that we do quite consistently. In terms of Bon's already covered it, but we do have a beautiful mix of paid and volunteer peer support practitioners that work alongside the clinical counselling staff. So that complete practice integration, multidisciplinary approach is really what enables us to be able to meet people in that moment and give them that choice in terms of what they would like to see and experience from a support perspective. So that is something that we offer from a lived experience peer perspective, or whether they need that clinical insight. There's just a brief overview there, just in terms of the intricacies of the intensive care and counselling programme, which we cover in Victoria and Queensland, which is a free service. You know, we do request that referral is required, and it's staffed by clinical counselling and peer support pracs. And it's an intensive medium-term support. So over various months, we continuously support and do those risk assessments and safety planning to remove those sort of complex barriers for those individuals accessing care. We also encompass the secondary consultation service for healthcare providers as well. Next one, Bon. And then back over to you, Bon. I'm not sure if we're going to have enough time to just provide the case study.
Wrap it up there.
Yeah.
Did you want to just quickly talk about some of the referral pathways, Kirsty? You might just move to that.
Thanks, Inez.
Yep. Kirsty,
over to you. Yeah, do you want to go through, Bon, in terms of what that referral should look like?
Yeah, absolutely. So in terms of referral to Panda, any information that you can provide us about if the person has a preference for time of call, if there are any safety or family violence concerns, we can offer counselling with male, female and gender diverse counsellors and peer practitioners as well. Incredibly helpful to know if they have any language preferences. In terms of our service parameters, if you're supporting a family bereaved by perinatal loss, whether that's pregnancy loss, neonatal or infant death, please include the baby's name with the referral when you're referring them, with the person's consent, of course. Also, just briefly want to mention that we do provide whole of family support. We don't provide couple or family counselling or peer support on the helpline. However, if you're supporting a couple and both partners are struggling, with their consent, you can refer them both to Panda, and we work with all of our callers in that stepped care of intensity. So they might come to the national helpline, work with a counselling and peer practitioner. Service coordination is needed, but always with that focus on working with our partner organisations like Lifeline, Beyond Blue, SANE, Pregnancy, Birth and Baby and Red Nose, and ensuring that callers are linked with community-based care as well as support from Panda. And
so thank you. I might just ask 2 or 3 brief questions. That was terrific. And the participants will also get the slides, so the information will be on there as well.
Great,
so
thanks.
Let's a few questions from my point of view. Firstly, congratulations on the secondary referral line. So for the GPs and other providers out there, that's a great opportunity where you can ring and get advice for you in supporting the women and families that you look after. So that's a fantastic sort of new initiative. The other thing I was going to ask, is it all telephone based? Do you also have video, and do you also have face-to-face?
No, we don't. So at the moment, Panda is funded for telephone-based care. So we
That's
do,
fine.
yeah,
And
some of
do
our
you
other
have,
teams work in the community, but helpline is telephone.
but any Panda facilities work in the community, or is it all telephone-based support and case management and care navigation?
Yeah, it's all telephone based. As we offer SMS follow-ups and emails, but currently the funding restrictions that we've got at the minute just don't enable us to provide that. But it's definitely something that we're looking into in terms of web chat, face to face, video counselling potentially. So it's
room for movement. And
yeah.
do you use telephone interpreting services when required?
We do, yeah. We've got interpreting
And the other
services, yeah.
thing is, do you also have free services for non-Medicare eligible women and families?
No, Medicare is required. That's the best. Yeah, obviously, I yap about Panda because I'm fairly passionate about the support that we provide, but people can self-refer, be referred, so long as the parent is residing in Australia, no Medicare, no diagnosis. So even if someone's just feeling a little bit unokay,
so
yeah,
no
refer them
Medicare.
in.
So
Yeah.
non-Medicare eligible. That's fantastic. So
Absolutely.
that's really wonderful too. So
Yeah.
thank you so much
Thanks,
for your
Miss.
help, Bonnie and Kirsty, and we'll make sure that we get the slides out. So thank you very much.
Thanks for
I'm
having us.
just going to share the rest of my slides now. Here we go. Oops, the current slide. I should get used to this, shouldn't I, after all these years? So there's the information for Kirsty and Bonnie. And look, we all know about Panda, but it's great to know they have an increasing offering and capability to care for the women and families that we look after. So now I'd like to introduce Dr. Charles Sue, who's a consultant psychiatrist with a keen interest in psychotherapy, perinatal psychiatry and adolescent mental health. Graduated for the University of New South Wales, but we'll forgive him for that, and completed a Master of Psychiatry. Works across many hospitals in Sydney and Melbourne. Most importantly, works with me, alongside me, on Yellow Clinic in maternity care on Wednesdays, which is tomorrow morning. So it works as a consultant psychiatrist alongside the maternity team. He's got a rich exposure to complex psychiatric presentations and has a dedicated perinatal psychiatry training. His clinical practice focuses on providing holistic and evidence-based treatment for parents affected by mental illness during pregnancy and the postpartum period. And Charles has also recently started a psychotropic medicine service at the Women's Too, which we'll talk about. Thank you very much, and over to you, Charles.
I can't hear you, Charles.
Can't hear you yet, Charles.
What about now?
Now's good. Right.
Perfect. All right. Can everyone see the slides?
Yes.
Perfect. In line with the interest of time, we might quickly go over some what I think may be helpful points for practicing GP who are managing perinatal mental health presentations. Thank you to the Panda team for doing a brilliant overview on some of the common perinatal mental health symptoms. A very quick note about postpartum psychosis, in addition to lack of sleep, if the person has significant bipolar family history and they present with sleep changes and personality changes in the postpartum period, irrespective of their past psychiatric symptoms, one must be very vigilant about emerging psychotic episode. So that's one other thing to keep in mind of. I want to quickly go over some of the common severe depressive disorder in pregnancy period that we often see, and also in the frontline workforce, GPs and psychologists alike will probably get these presentations as well. So we know that in Australia, more than half of the patients will stop their antidepressants almost immediately without consultation to their primary prescriber when they discover they're pregnant. And that is a concern because we now know the risk of antenatal depressive illness relapses is actually just as big as the postpartum period. So relapse prevention is crucial. On top of that, we know that in the antenatal period, the mood changes is often insidious and slow, and it's often not well recognized or reported despite having good screening tool like COPE and depression screening scales. And the issue with relapses without cessation is there. In the context of peripartum depression, we now know that there is a strong biological root, which we can talk a little more about later. But many surveys and many studies have noted that without treatments, the relapse rate is significant. And in the antepartum depression itself is a predictor for postpartum depressive periods and carries a lot of various risks that we can think about. We acknowledge that the postpartum depression itself is not only a serious but common disorder that we screen and treat. And the prevalence in Australia really ranges, depends on the studies, but overall most studies quote around 1 in 8 to 1 in 10, much like what the Panda have reported as well. 1 in 5 of the antenatal depressive disorder will persist throughout the pregnancy, and 1 in 10 of the postpartum depression will eventuate to a more sinister chronic major depressive mood disorder. And despite our best effort in educating and screening in midwifery appointments and GP and psychologists, many people are often blindsided by the onset of postpartum depression, not only because of the fact that often people are anxious and worried and often try really hard to prevent it, but also postpartum depression itself has a very different biological root now. We now actually hypothesize the etiology of postpartum depression is to do with GABA or in specific neurosteroid level falling as opposed to the traditional serotonin pathway. So the onset of time frame is a little bit different from the general adult depression, that depressive disorder. But in line with the fact that there is a crossover and the continuum of some of the mood disorder between prenatal and postpartum, our current approach is not actually distinguishing them as two entities, antenatal versus postpartum depression, but rather we really try to emphasize on the perinatal period and the perinatal disorder and treat them as a whole and prevent them as a whole. The textbook period, peripartum period, refers to pregnancy all the way to 12 months postpartum. In the public health sector, most perinatal mental health services have some sort of postpartum support timeframe, but it's highly dependent on the hospital you're working at. The Royal Women offers support up to 3 months postpartum in terms of the perinatal psychiatric support. Joan Kerner offers up to 12 months, and Austin Mercy and Monash offer up to 3 to 6 months, and it's case by case. So when you're referring and treating patients in that period and referring them to the relevant perinatal psychiatric services, it's worth bearing in mind the time frame of which you're seeing the patient. The symptoms of peripartum depression is actually, again, a little bit different from the general adult depressive disorder, and that relates to not only the psychological transition that motherhood is that's so unique, but also the biological root behind it. Like we said, there's a fall of neurosteroid that we hypothesize as the main cause of peripartum depression. The depressive disorder in the pregnancy period is often more affective in nature. There's often comorbid anxiety symptoms. People often talk about sleep changes, appetite changes, and the important thing is there's this kind of inward looking anger toward themselves, this self-criticalness around they are unworthy, they're a failure, they're not going to be a great mom, they're unable to be a great partner. And that leads to a lot of distinct impairments, not only in their capacity to work, their capacity to manage their relationship, but also they may think about, because I'm so unworthy, I may as well kill myself or kill my baby. And that's where these suicidal and homicidal thoughts come in. Like the Panda team pointed out that these thoughts of harm, whether it's to self or baby, may not necessarily be the true thoughts, in that they may not believe in it. And we also acknowledge that the peripartum depressive period can have these obsessional themes that are ego-dystonic. And in fact, the other thing that we screen for in our psychiatric clinic, in addition to peripartum depression, is peripartum OCD, where people present with often obsessional thoughts around harming baby without compulsion. So it's, again, all of these symptoms distinguish kind of PND from the general major depressive disorder episode by itself. It's not to be confused with baby blue. We know that baby blues are incredibly common, and it's actually as common as 80% of the birthing parents experience that. It's a transient symptom, and often people talk about light bulb moment. The day before they're fine, the day after they wake up with this teariness and anxiousness that come and go during the day. These symptoms of baby blues don't usually interfere with mom's capacity to look after baby or their ability to concentrate on their task. It's most commonly day 3 to day 5 after birth, but can occur really anywhere within the first 14 days of birth. Without having to do any treatments, it self-resolves usually by day 7 and latest by day 14. If the symptoms are intensive to the point that it consumes the parents, they're telling you they can't look after baby, they don't really feel the baby, they can't even focus on talking to the parents, or if the symptoms persisted beyond 14 days postpartum, that's when we need to be very vigilant that whether we are seeing an emerging major depressive disorder in the peripartum period. In addition to the impairments that peripartum depression causes on bonding, attachment in the family unit, the other thing that we think about is the risk of suicide and infanticide. There's been a lot of studies looking into moms that committed suicide within the first year postpartum period, and a lot of studies have quoted kind of 8 to 10 folds of increased risk of suicide if mom presents with a postpartum depression. And for a lot of reasons, but we also think it's, again, so biologically driven, and this difficult psychological transition compounded on it. These suicide attempts often result in a more aggressive and violent means, and often impulsive in nature. This is a really old studies now, but I still think the stat is helpful. The leading cause of maternal death in UK is in fact to do with postpartum depression. And in 2010, again, a little bit outdated data, but it was the 3rd leading cause of death in Australia. Now that we recognize peripartum depression is a common and it can be quite a serious disorder, how do we treat it? The reality that many of you face is that it's a very difficult conversation. Like we said, people are already stopping their treatments when they discover they're pregnant. How do you convince themselves to go back on treatments when they are pregnant, worrying about the baby as part of the depressive disorder, and already self-blaming as part of the depressive cognition? The first thing to acknowledge is that there is no risk-free option. We now know untreated severe depressive disorder or severe anxiety disorder itself can also lead to poor obstetric outcome, let alone poor bonding and attachment to baby. The risk of emergency C-section, premature labor, and preeclampsia actually increases dramatically in someone with a major depressive disorder. If the patient has severe disorder that needs a psychiatric admission in the pregnancy period, that itself, that one admission also increases the risk of poor baby neonatal outcome as well. So not treating them with medication itself is also not risk-free. Ideally, we would optimize all the pharmacological agents that, that I trust many of you would do. Try to promote sleep, think about psychological treatments, Panda, all these kind of resources, optimize the bubbles that they have around them so the patient feels supported. Address the substance use, address the physical illness that may be compounding on the pregnancy discomfort and the depressive symptoms. And when it comes to using medication, there are so many different things we have to think about, and there's really no right answer because there are various factors whether we need to think about. we need to think about what are the past responses to treatments, what got this person well before, and what would the side effect profile, how would that sit in the pregnancy period? For example, if the person got severe nausea from antidepressants, then restarting in the pregnancy period, depends on which point of the pregnancy, may be a little bit tricky, and we may need to think more about it. And does the patient have any preferences as to which medication that they think have worked best for them? When possible, it is very important to include their loved ones, their partners, in the discussion, not only to educate them that what you're seeing is a psychiatric illness that can be treated, but also to include these bubbles of support as part of the safety planning and empower them. And really, what you want to do in this assessment phase is almost a bit of psychological first aid for the patient and the partner, that there is hope, that things can be better, that this is not all doom and gloom. We know that all the medication we use, even beyond psychotropic, in pregnancy goes through to baby. The main issue is, of course, that we don't quite know how much of the psychotropic we use goes to baby. So what we do in research, we take a placental passage. So when babies are born, we take a blood test from the placenta area and guesstimate how much medication goes through to baby that way. Obviously, that's highly inaccurate. Depends on the timing of the blood test, the labor, the blood loss, the resuscitation with fluid or not. The dose range varies, but most psychotropic, when I say that here, I mean most antidepressants have guesstimate range from 21 to 33% placental passage during pregnancies. The timing of treatment is critical because it does lead to, in terms of the risk-benefit discussion part, what you want to inform your patients of. If we think back to our embryology and our obstetric care, we know that ideally, in the ideal world, we want to avoid any sort of medication exposure within the first trimester, because that's where most of the vital organs are formed. When it comes to prescribing in the later part of pregnancy, specifically late second trimester to third trimester onward, the other thing we want to think about is the potential functional impacts. Not only are we thinking about IQ, personality, but also on the more severe spectrum, the linkage with neurodevelopmental diversity or neurodevelopmental disorders such as autism or ADHD. This area is very, very murky, and the evidence is very much emerging. So it's very worth your time to keep an eye on these newest evidence, because even within the psychiatry realm, there are basically two big camps looking at this at the moment. And at the delivery part, we also want to think about, if we were to use psychotropic medications, how would that impact on babies' transition out of the uterus? So what we are talking about here specifically is the risk of neonatal adaptation syndrome, NAS. So these are kind of like the broad categories of what you want to think about, and the timing of the pregnancy when you are treating the patients with a depressive disorder that needs medications. The reason why it's hard to develop a consensus or a great nationwide guideline, first line ABC, second line ABC medication, is because you can't randomize control these patients, and the evidence itself is often murky. So we can only rely on prospective cohort study, which isn't great. And of course, even looking at these studies, we need large sample sizes, when we really big one, to kind of justify whether some medication is really linked with increased risk of malformation. I want to highlight that in a non-exposed, non-psychotropic exposed population, the baseline congenital malformation rates, depends on what studies look at, but in Australia, sits around 3 to 4.5%. So it's important to bear that thought in mind, that just because someone isn't on medication, that malformation risk exists. But all of these things really highlight the difficulties with doing a nationwide or international guideline, because the quality itself is limited. Compounding on that, we know that people with a more severe psychiatric illnesses often don't necessarily have great lifestyle, in that they may often come from a lower socio-SES family, they may have comorbid substance use disorder, they may have metabolic problems, long-term antidepressants, long-term antipsychotic use increase your risk of cardiovascular diseases. That will also lead to poor obstetric care. So all these confounders make a great study very difficult. So with that in mind, what do we actually do when we try to consent these patients that need treatments? There are various ways to do it, but in perinatal psychiatry, we think about how do we consent people with risk and benefit analysis. In the perinatal time frame, I often think about risk benefit in these 4 different categories. We think about the risk and benefit of this medication to the unborn in pregnancy, and that includes the impact, the potential impact of longer-term neurodevelopmental outcome. Again, there's no great studies on that, and what we often say to them is that the study that highlight concerns of increased risk of ADHD, ASD often don't account for family history very well, and the study sample size are very small. Last we checked in APA in New York, there really isn't great studies on that. So the focus is really on the congenital malformation risk. We talked to the patient about the risk and benefit of the medication to them, and that really is highlighting the benefit of treatments, because we know that healthier mom on all front often leads to healthier obstetric outcome, let alone the emotional outcome. We also talk about the risk and benefit of the medication in the initial neonatal period, the first 24 to 72 hours. This is crucial because a lot of the medication we use can lead to withdrawal in baby. Thus, the neonatal adaptation syndrome is something that we do want to highlight to them off and think about how do we monitor them. And the last thing we talk to them about is the risk and benefit of this medication in terms of breastfeeding setting. Not all psychotropic converts to breast milk in an acceptable range. So we want to be mindful of, if the patient were to be on this medication, not only in pregnancy, but beyond pregnancy, what does that then mean for their breastfeeding practices? It is very important that when we do these risk and benefit analysis, we are thinking about this specific patient and comparing this to when they were last well, and not to compare them to the next person who has no psychiatric history, no psychiatric symptoms, and is completely well and functional. The risk and benefit really needs to be specifically tailored to this person's status. The other way you can think about it is, if you want to write it in your note, in your letter, you can think about the risk of malformation, obstetric complication, again, NES, and the longer term risk and breastfeeding consideration. But I tend to like them broken down in these 4 categories, a little bit easier. We want to avoid medication that is highly teratogenic, and we want to avoid medication with not sufficient safety data, so that eliminates the newer medications. There are a few medications that we will not prescribe, and sodium valproate, carbamazepine, topiramate, these 3 really are not advised for various reasons. In fact, sodium valproate, we now know, even when someone is on high dose folic acid prophylaxis, the longer term outcome is still very poor. Babies are very likely to have lower IQ and very poor language and social skills later down the track as well. I want to quickly, in the limited 5 minutes that we have now, do we have 5 or 10 minutes? I think
10, you've got 10 minutes, Charles.
Perfect. I want to quickly go through some of the common myths about antidepressants, specifically SSRI. So SSRI, as we know, are specific serotonin reuptake inhibitors. The College of Psychiatry, and I'm sure RSCGP still lists SSRI as one of the few first-line classes of medication that we can consider for a depressive disorder or anxiety disorder. And certainly in most of the perinatal psychiatric review, it is still indicated as the first-line medication if risk-benefit discussion were had. I want to highlight this is in the Australian context because in the USA, they now have brexanolone and zuranolone, which is specific neurosteroid replacement as the first line for postpartum depression, but that's not available here. We have a very high rate of SSRI, SNRI prescribing in OECD country. In fact, we are the 2nd highest user of antidepressants, only second to really not many other countries. And that does lead to these discussions around what do we say to people, how do we counsel them, or what do we counsel them on when we are thinking about SSRI. We know that it doesn't cause fertility issues, and there's now very good evidence that SSRI and SNRI do not lead to miscarriage, in the sense that it doesn't increase the risk of miscarriage. Again, acknowledging that in Australia, the 2020 consensus noted that the background miscarriage risk is about 10 to 15%. That rate will vary and dependent on their ethnic origin and their other comorbidity factors, but the overarching rate is around that point, and people who are exposed to SSRI, SNRI do not have a higher rate on that. It is, in summary, there's no impact on fertility I want to stress that antidepressants, specifically SSRI, SNRI, do not increase the risk of miscarriage, noting the background risk in Australia is about 10 to 15%. We now counsel women who are on SSRI, SNRIs, specifically citalopram, escitalopram, about the increased risk of postpartum hemorrhage. There's really good Nordic studies to look at this, and the increase isn't that great. It's about 3 to 5% of absolute increased risk, but again, that risk is there, so we do counsel women on the potential of that. And SNRI and tricyclics, which makes sense because the noradrenergic action, people are often at higher risk of having preeclampsia. So blood pressure monitoring is something we want to think about. SSRI is probably one of the few medications that is in many ways over-researched. In fact, every year, every perinatal conferences I've been to every year, there's always new studies looking at the impact of SSRI. But as a class, it's very clear now people who are exposed to SSRI specifically do not have higher rate of birth defects. There may be some medication-specific variation, but overall as a class, the results have been very reassuring. And if you think about it, SSRI has been out there for so many decades, and the fact that every year there's a lot of discussion, but the signal is not extremely strong, that itself is reassuring. SNRI, the studies on it is a lot less and is more limited, and the one with good quality is even more limited. But of the ones that we do see, again, there's no clear impacts on birth defects. The main thing we talk to them about is the risk of pulmonary hypertension in newborn, and the increase depends on how you discuss this with patient. You can either tell them that the increased risk specifically with SNRI is from 1 in 1,000 in the non-exposed population to 3 in 1,000. Or you can tell them it's a threefold increase, but I think it's important to provide the context. Sertraline, of all the SSRI, SNRI, for whatever reason, is thought to be the one that's least likely to be associated with a more severe spectrum of pulmonary hypertension. 80% A0 of patients exposed to SSRI, SNRI in third trimester before birth will notice some sort of neonatal adaptation syndrome in baby. Usually these are irritability, jitteriness, and a little bit difficult to settle. The one that have more severe complication or severe spectrum of neonatal adaptation syndrome is often not because of SSRI alone. It's often medications, multiple ones, a difficult birth, something else happened. Nonetheless, something that we do monitor. The only medication I would like to highlight is the use of duloxetine, which is a common SNRI. The common trade name is Cymbalta. Cymbalta is probably the only one that has been more consistently demonstrated to have a stronger link to a more severe spectrum of neonatal adaptation syndrome. So in an ideal world, we want to keep people away from those medications, but again, we want to do a risk-benefit analysis for them because, for example, if duloxetine was the only one to keep this patient well, then you want to think twice about what we do with that. The longer-term cognitive deficit.
Charles, could I just ask a question? With severe neonatal adaptation syndrome, is that related to the amount of medicine that they're on, or is it somewhat sort of precious? And has it ever resulted in death of the neonate?
Yeah, so the one that had resulted in very bad outcomes, like Inez pointed out, like severe breathing difficulties to the point leading to permanent brain damage or death, are usually SNRIs, and again, are usually high-dose SNRI and many other things that have gone wrong. It's incredibly rare that we see a person just on a medication alone that has a severe spectrum. SNRI, specifically duloxetine high, some studies in APA this year, they look at the study dose exposure, and some studies have concern around duloxetine higher than 90 milligrams seem to be a little bit stronger linked with a more severe spectrum of presentation. The long-term neurodevelopmental part is very much non-clear, but most of the good studies don't support that because there's a lot of different factors into what neurodevelopmental disorder may look like, but the largest scale studies really have not supported strong linkage between SSRI exposure in utero and longer-term neurodevelopmental issues. All of them can be found in breast milk. Most of the studies noted are kind of like 1 to 3% of the maternal dose, and there's no current evidence to support breastfeeding and longer-term problems if they were to be using SSRI SNRIs. Mirtazapine is another common medication that we use, and lots of people, I like to use it too for patients because it helps with sleep, but we want to be mindful of the postpartum period if that were to be your choice of agent, because with a newborn period, it may be difficult to have consistent sleep. And if mirtazapine is sedating, then it does cause an issue. There's not so much larger scale studies, but overall, the evidence is really reassuring in that there's no increased risk of birth defect. There are still concerns of neonatal adaptation syndrome, but the overall linkage to the severe spectrum is a lot less than SNRI. Antipsychotics overall, very briefly, Professor Nick Hex and Professor Judy Hope did a very big pharmacology reviews this year, and their overall consensus is quite reassuring in that of the very limited large-scale studies that we have, there's really no linkage between exposure of babies in utero to atypical versus congenital defects. Granted, these studies really look at the older types of atypical, so it does not include things like cariprazine, brexpiprazole. There are some concerns around first-gen antipsychotics in first trimester exposure. There are some case reports that supports that raise concern around limb defect and birth defect in first trimester exposure, but that really hasn't been replicated later on. The main thing you want to be mindful of is much like how they will impact patients' physical symptoms of EPSC, we hypothesize that babies that were born with exposure to antipsychotics, depending on what type and dose, may also have some transient EPSC in up to 4 weeks after birth, but these certainly can be monitored. There are some specific medication-related side effects and adverse events that we counsel people on, but if you're ever unsure, it's really worth checking with a psychiatrist or with the medication information services of the Royal Women, because there are some specific differences. The longer-term neurodevelopmental outcome is still being monitored. We now notice that a lot of the studies have seemed to detected possible motor emotion and emotion developmental delay at 2 months point, but these delay don't seem to be persistent and certainly resolve at the 1-year screening. There's a lot of reasons as to why that's the case. We don't quite think it's to do with the actual medication exposure on the growing brain, but more the fact that a mom with enduring psychotic disorder may not necessarily always attune to babies' kind of nuanced needs to grow and develop with their language and emotional skills. And we hypothesize that as one important factor as to why these delays were picked up in some of the screening. Because if you think about the actual pharmacology, it doesn't quite explain why the delay occurred. There are some small studies, again, noted concern of ADHD in these kids that were exposed, but the quality were really, really not that great. Clozapine of all the one is probably the one that's reasonably reassuring in terms of neurodevelopmental outcome obstetric outcome and the actual congenital outcome, it's been thought to be quite safe. The main thing is to know the metabolic impact in pregnancy, really. We know that people are already at risk of gestational diabetes, and people on clozapine are at even higher risk of it. If moms were on clozapine, then the main thing we want to counsel them on is to do with breastfeeding consideration, because it does go through breast milk, and we hypothesize the impact of baby is possibly similar to the impact in adults, in that it increases the baby's risk of seizure, agranulocytosis, and possible cardiac issues. So we counsel them against breastfeeding when using clozapine.
Oh,
Are we running out of
Charles,
time?
yeah, no, you will run out of time in a minute,
Yeah.
but I've got a question first, which is, there's a question about, is the mode of delivery important as well with regards to depot, or is it about the medicine itself?
Yeah, so depot, there's not great studies, but in reality and in practice, a lot of us do try to transition people on depot. And this is specifically important if you have a patient with an established enduring psychotic disorder or an established bipolar disorder, because at the 3 years and 5 year study, it made sense, right? Because we have a depot, the serum steady state is more consistent. You're more likely to prevent a relapse that way. Compounding on that, we know most of the antipsychotics, with the exceptions of really 2, are sedating. So it's very difficult for women to be on them when they have a newborn. So depot eliminated that kind of impact as well. So in practice, we try to switch them to depot when possible.
Is there anything else you wanted to highlight, Charles?
I think that lithium itself is a very different tox, but again, I want to just quickly highlight that we know that cost epsilon anomaly, but the actual absolute increase rate is not as big as we used to think. So it's about 0.6 versus 0.18. Still a increase nonetheless, but it's not an absolute contraindication like we used to think. So again, if you have someone who with severe bipolar disorder that needs to be on lithium and has only been well on lithium, it's again worth considering what you want to do as well. If you're ever unsure, in addition to the women's PBMG guideline, we have a medication service, and we now also run a medication counseling psychiatric service where we see people who are planning to fall pregnant or have just fallen pregnant, but within the first trimester, that aren't booked in yet with the maternity service, but really want to discuss these kind of risk-benefit nuanced discussion around psychotropic medication use. Happy to see them enroll women. Please refer them, and we talk about all sort of psychotropics, including ADHD medications. I think that's pretty much it.
Thank you so much, Charles. I might just share. Let me just see if I can manage to share this. Share. What am I trying to share? Stop sharing. You are sharing a screen. Can you stop your sharing? I think I can't get it. So just a few questions just to recap, just the issue about lithium. One of the issues obviously is the breastfeeding with lithium, isn't it? It's as well as the antenatal period, it's the breastfeeding complications. Is that correct?
Yeah, so if the mom is on lithium, so I'm trying to stop sharing.
It's on and it's a screen now. Thanks.
Yeah, I think I stopped sharing now.
Oh, great. Okay,
Yeah.
fantastic. Yeah.
Yeah, so if someone is on lithium, unless they are prepared for the baby to have very, very regular blood tests, really we advise them against breastfeeding because they also go through breast milk. Lithium is lipophilic. So that's the other thing. If your patient's lithium level all of a sudden dropped and when they've been stable, it's worth asking, are they drinking lots of milk? So it does have this higher infant dose ratio in breast milk. Then that's the other issue.
Right. Am I sharing my screen here?
Yeah, but it's just a section of your screen. Maybe you can unshare and
oh, that's better. I just wanted to highlight, so that was a fantastic talk, and we could have done another few hours on that, but I just wanted to highlight the issue that Charles was raising with the maternity. So Charles has started a maternity psychotropic assessment service. It's a new service at the Women's, and it's basically for women, not for diagnostic purposes, but for women pre-pregnancy, pregnancy, or in breastfeeding. who are taking psychotropic medicines and actually want to have that discussion about risk benefit. And so he'll give a very holistic, it's a one comprehensive consultation where he'll meet with the woman and also provide you as GPs with the analysis of that consultation. And also just a reminder that we have the Medicines Information Service at the Women's, and they provide fantastic, there's, specialist pharmacists that provide fantastic advice, and also have the psychiatrists as a backup. So that's something that's valuable. And also, Charles, I've got 3 or 4 questions in the chat about the use of ADHD medicines, but I think you talked a few times about the fact that it's a bit of an evidence-free zone at the moment. Evidence is emerging and people are treating that differently. Would that be correct?
Yeah, and I want to highlight that ADHD meds, of course, there's the first-line stimulants, but they're also non-stimulants medication. The reality is none of these medications have sufficient evidence to back it up in terms of the long-term use. And the ADHD psychiatrists that endorse continuing them is really resting on the fact that really resting on the absence of horrific outcome. They're kind of betting on, so far there hasn't been anything like sodium valproate's impact on pregnancy, as opposed to having a robust, really good large-scale studies. So there is differences. And it's not entirely benign in that we know that there's actually, especially in the US and North America, where stimulant use is more prevalent and more commonly prescribed, there is an increased risk of preeclampsia, preterm birth, when someone is on stimulants medication in 3rd trimester. And there are still some potential concern on cardiac abnormality if they were exposed and used in 1st trimester. So it's not only the lack of evidence, but also there are some currently available trends association that's worth discussing with your patients. This is for stimulants specifically.
Thank you very much, Charles. That was absolutely terrific. And again, people will send the slides so you'll get some more information there. And I'd like to now pass over to the Parent Infant Research Institute, PIRI, that are housed in Austin. And we've got Dr. Michelle Byrne, who's a clinical psychologist with a special interest in perinatal infant and child psychology. And Bridie Garner is a research officer with a strong background in psychology, focusing on parenting and child mental health outcomes. So thank you very much, Michelle and Bridie. Are you happy to share your slides, or would you like me to?
I think Michelle is going to share.
Perfect. I'll stop sharing them. Thank you.
Thank you very much. Confirming that you can see our slides okay?
Yes, we can. Thank you.
Wonderful. We are very happy to be presenting to you today and to be lucky last in the session. So thank you, Ines, for the handover. My name is Michelle. I'm a clinical psychologist at PIRI, and I'm presenting with my colleague today.
Hi everyone, I'm Bridie and I am a research officer at PIRI, and I project manage the Mum Space initiative, which we'll be talking to you about today.
So today we are going to be talking about Mum Space, so thinking about supporting mental and emotional well-being for women during pregnancy and after having baby. We're going to talk in detail about the Mum Mood Booster program specifically, and also for GPs and other health professionals that we have here today, the clinician portal where you can refer directly into the Mum Mood Booster program. So before we go any further, I just wanted to take a moment to acknowledge the traditional owners of the land on which we join today, the Wurundjeri people of the Kulin Nation, and pay our respects to the elders past, present and emerging. We pay our respects to other elders and to all Aboriginal and Torres Strait Islander peoples. At PIRI, we're committed to creating a safe and welcoming environment for all Aboriginal people. So firstly, just to touch on Mum Space. So for those of you who may not have heard of Mum Space, it is an online digital platform, and it's designed to be a step care model, which is supporting women during the perinatal period, so during pregnancy and after having baby. It's designed to support all women. So in the step care model, there is universal and preventative resources that are evidence-based, programs such as this Baby Steps program, and then stepping up into supporting women who may have emerging symptoms of mental health difficulties or subclinical symptoms. And an example of those support services is the Mind Mum phone application, and then stepping right up into freely evidence-based treatment programs for women who are experiencing a diagnosis of antenatal or postnatal depression. And that will be thinking about our Mum Mood Booster programs. So you can now directly refer into the Mum Mood Booster program. And if we're thinking about what that might look like, so during the usual emotional health assessment, whether that is with a screener using the Edinburgh Postnatal Depression Scale, for example, there's an indication that there may be a need for support and depressive symptoms. Women may go on to receive a diagnosis of depression, and they can be supported directly into the Mum Mood Booster program through the clinician portal. There is also the option for health professionals to provide information about the Mum Mood Booster program, and mums can refer directly into the program themselves. Just a note to say as well that the program is a good fit for women who may be experiencing depressive symptoms and not meet the full diagnostic criteria for antenatal or postnatal depression. So the Mum Mood Booster program, that is our central cognitive behavioural therapy program. It is designed to be delivered and online and be comparable in its benefits to face-to-face CBT treatment. It is tailored and adapted for this perinatal period, and there is a version to support both antenatal and postnatal depression. So alongside this, there is phone coaching support, and as our Panda colleagues have said earlier, that is provided through their service for our high-risk users, and there's also email alerts if needed, if there's any risk concerns where crisis and additional supports are provided.
So Mum Mood Booster is the first Australian e-treatment that has been designed and validated for the treatment of diagnosed postnatal depression. And as you can see on the screen, it's been trialled in many clinical studies in both Australia and the US. The most recent randomized controlled trial was a 3-arm trial, and it found that the Mum Mood Booster program was as effective as face-to-face CBT, even for women with severe symptoms. And most recently, we've run some feasibility studies for the Mum2Be Mood Booster program, which is the antenatal version. So following all the RCTs, Mum Mood Booster was funded by the government to be rolled out nationally in Australia. So it's freely accessible to women and has shown benefits in the real world with rapid symptom reduction measured by the PHQ-9 during the course of the program. So just for some figures, annually we average around 48,000 visits to Mumspace and about 2,000 program registrations a year as well. So we're reaching a good amount of women. So the Mum Mood Booster program has many benefits, given that it's freely available. Women can access it 24/7. It's easy to use, effective, and it's highly personalised for women to work through their own issues and develop strategies for dealing with them. It can be used to complement existing supports or when face-to-face services is limited. And it can be used by clinicians using our dedicated clinician portals as well. So for all users, Mum Mood Booster provides weekly motivational SMS messages to increase engagement and just provide a little bit of extra support. And as Michelle mentioned, for women who are at a higher risk with an EPDS greater than 15, they are offered supportive phone coaching through Panda. And that has shown to improve effect sizes, treatment adherence, and just provide that secondary safety net in case some of them experience symptom worsening.
So this is a very brief snapshot of what is inside the Mum Mood Booster program. So it is a CBT-based program, as we've said, and there are 6 sessions that can be accessed by women, designed to be completed weekly. participants can jump on and stop and start as needed, which we know can be really helpful if they've got a little one there with them that they're caring for. The sessions look at the providing psychoeducation, behavioural activation and cognitive strategies to support mood, as well as relapse prevention. It also comes with a list, a library of additional resources with topics such as understanding your baby's needs, thinking about the adjustment in the partner relationship and communication skills. So alongside this, there is the option as well for women to send an invitation to a partner support website. So we're holding that little family in mind in what this period looks like. And the Mum Mood Booster program itself with these features is interactive. So there is experiential components within the sessions where there is the practice change activities. These can be entered and tracked on the website and can be personalised as well as they're going through the program. So I think we've noted this as well. We're talking about Mum Mood Booster kind of suite of programs. There is the Mum to Be program specifically for women during pregnancy, and this is an adaptation. So it's very similar structure and content, but again, it's been tailored when we're thinking about the specific considerations for women during that antenatal period. So the newer development for the Mum Mood Booster program is the clinician portal. And so this is designed for GPs and other health professionals to be able to refer women who need this additional support directly into the program. So if you're interested in joining, we can send your team brochures, we can provide them later, but you can also use the QR code now to sign up onto the clinician portal. So there's a couple of very easy steps. It is registering for an account, and you'll be provided a unique code, and that then will be given to patients that you refer into the program. They then will register and complete a self-assessment. And so there's some screening tools that we use at that point in time, including the Edinburgh Postnatal Depression Scale. We also use the DSM-5 cross-sectional screener as a part of that assessment upon registration. So within the clinician portal, there is the capacity to monitor the mother's engagement and symptom improvement across her journey within the program. It is tailored that for GPs and other health professionals, you can choose the level of involvement that you have in terms of that engagement and monitoring of their progress within the program. Importantly though, if there is any risk concerns that are flagged within the screening measures, so women also complete the PHQ-9 as a monitoring measure, they will get an alert sent to their email, as well as a list of resources and information within the program, and a copy of that will be sent to clinicians as well to their email account so that they're aware.
Oh, so that's, I think you answered my question, Michelle. So if a GP is also involved in that and there's some deterioration, they'll get an email notification of that to whatever they've registered to.
They will, yes. So, and they can also then, all of the details of the report won't necessarily be within that email, just for confidentiality. It will be that flag, but you can go on and there'll be a report then of the outcome of what women have completed in terms of those risk indicators. This is just a couple of screenshots to show what some of these reports look like. So to the left, there's the screening and activity summary. So when you log on to the clinician portal, this is an example of what you'll see in terms of what women have completed. There's an overarching score of the Edinburgh. It will flag if there is a risk indicator on item number 10, and it will also give a breakdown of that DSM cross-sectional screener as well. And this is an example of the risk alert that's sent to patients in terms of access to crisis or additional supports. And the program is designed to be integrated into your practice in a way that suits your needs. And it is open to, other health professionals too, who may also use it as an adjunct when we're thinking about holistically the treatment and support of women during this time.
So we just thought we would mention that since Mum with Booster is based on years of evidence, we are in the process of updating the program just to be a bit more user-friendly when used on mobile devices. This is based on consumer feedback, and we're also updating the look as part of that, as you can see on the screen there. So we just want to say thank you for listening. It's been great to present to you tonight, and we hope that you find the clinician portal and the Mum with Booster programs useful as part of your practice. We would love your feedback on your experience with the portal. And when you register for an account, we do send you a feedback form. So we would love if you could fill that out, and yeah, you can reach out to us if you have any feedback or questions as well.
Thank you, Bridie and Michelle. I mean, I think that this space is really important. I mean, increasingly, we're going to have a whole lot of e-tools and AI tools, and often they're actually increasingly well researched and validated. So, and the accessibility is really important. I suppose as a cry out as a GP and for the other GPs online, that sort of integration into practice software is absolutely critical. The idea that GPs sort of have to go out of their software and get onto something else and have another web just sort of doesn't work very well. And also the clinical governance component of it, where it really needs to go back these things into your usual sort of checking software. So I'm sure these things will develop over time, just like the phone app will, and I'm sure that the the apps will as well. So that's but I think that this is the beginning of a really important access journey for women. So thank you very much for that. And just also, are they in languages other than English?
No, just English.
Yeah. Just a reminder, just a flag for that, and also just a flag for the issue about low literacy levels as well, because often women from a core background might actually prefer low literacy to English rather than others. But thank you very much for providing this. Somebody had asked whether this is similar to This Way Up. I'm not familiar with This Way Up. Are you?
So I know that they have, sorry, Michelle, they have a clinician portal as well. It's pretty similar. I think the program itself, though, is a bit different to how This Way Up does it, but I'm not fully aware of what their programs are.
And it's, it's great to see the evidence and research base behind it too. So thank you very much. And we've almost got back on time, which is great. It's surprising for me. So I might just, I think I'm sharing my screen. So just for some final areas, am I sharing my screen, Emily? Just tell me that I am.
Yeah, if you just go from current slide, I think it'll open out for you.
Beautiful. So just a few little things. Firstly, I'll do it at the end actually. So just there's the whole issue. Northwest Melbourne PHN just wanted us to actually put this slide up, which is really important, which is about accessing medical termination of pregnancy under 9 weeks in primary care. So again, if you'd like to, if you choose to become a provider of Perinatal, there's a little bar that you can actually, whatever you call it, go on to, and also do some training and support. And there's a lot around at the moment, so certainly would encourage you to do so, because there's a sparsity of it. Also, just to remind you that we have our shared maternity care workshops next Tuesday on the 8th between 7 to 9 online, and on the 15th, and that's we're the primary host of that at the Women's, but alongside the Mercy Northern and Western, and we have the register via the Northwestern Melbourne Primary Health website. Remember to subscribe to GP News at the Royal Women's Hospital, and that's the email of the GP liaison if you have any questions. You will be receiving a post-session email within a week, which includes the slides and the resources discussed during the session. And I would like to just do a big shout out and thank you to all of our presenters this evening. It was a fantastic session. I've learned a lot, and I'm sure that those around me have as well. So thank you very much, and off to your dinners, everyone. Bye.